So good morning, everyone, and welcome to today's Fireside Chat. This is going to be our 157th Fireside Chat, and good evening to our participants in Australia. My name is Dr. Yuri Okech. I'll be the moderator for this session, and today we're excited to have a guest speaker, who's Professor Kelly Lambert, who will be taking us through a topic on basics of nutrition for CKD and dialysis, and we'll be looking at case-based insights, this being our third nutritional webinar series. So just to take you through a little bit about Professor Kelly. So Professor Kelly is an associate professor with advanced accredited practicing dietitian and academic program director for nutrition and dietetics at the University of Wollongong in New South Wales, Australia. She has more than 2 decades of clinical experience as a specialist kidney dietitian. In 2023, she joined the Dietitian Associate Council of the International Society of Renal Nutrition and Metabolism. Her research, interests, and values are supporting people with kidney disease to live better lives, improving patient education by health professionals, and educating future dietitians. We're also extremely grateful to Professor Lambert for helping us organize the entire nutrition webinar series. That is to follow as the co-chair of the education committee of the ISN-RM. So again, welcome on board Professor Kelly, and looking forward to an enlightening discussion. Over to you, Professor.
Thank you so much, and thanks for the opportunity to talk tonight. Let me share my slides. I love talking all things renal nutrition, so hopefully this fits the bill for people this evening, and I'm very happy for people to email me through any questions that they may have that might arise from this presentation, or just generally, I'm very happy to talk renal with you. So as Dr. Yuri mentioned, this is the start of a series, so I thought it would be appropriate to start off with the basics, and then all of the following sessions that we will host for you on other particular topics relating to renal nutrition. So as you can see there on the screen, we have a number of topics, including gut health, phosphorus management, protein energy wasting, and so on. But we also threw a few really interesting and fun ones in there as well. So I've got a colleague who's going to speak with you about laughter therapy in dialysis and what impact that has, as well as exercise. So without further ado, let's start today's session. So what I thought I would do today was to cover some of the basics about what is the purpose of medical nutrition therapy in people with CKD. What nutrients do you modify and when? Because I think that makes people panic a little bit if they haven't had much experience or exposure. And the question that I get most frequently asked from people who are new to renal is, how do you manage competing priorities? And I'll show you a few cases and we'll talk through those about how I would manage those particular cases. So let's first start with a case. This is Mr. G. He presents to clinic. He's a very common scenario wherever you are, whether that's in Australia or in Africa. Mr. G is a 49-year-old male. He's been diagnosed recently with chronic kidney disease. His GFR has been stable around 55 mils per minute, and his ACR was 20 milligrams per millimole. You are asked to provide dietary advice to this patient, and what do you suggest? Now, as an experienced dietitian, I've already gone through a few things in my head to figure out what the dietary prescription is for this person. But what I thought I'd do is show you on a couple of pages how I would get to that conclusion. So first thing are my kind of rules for determining medical nutrition therapy for people with chronic kidney disease. So the first thing is to make sure that you let the eGFR and the urine results guide you when assessing the patient, because that helps you categorize them. Don't forget about the 7 functions of the kidney when you're doing your review of the blood tests and the medical history of the patient. And then the medical nutrition prescription for people with CKD changes over time as the kidney function changes. So therefore, there's not one renal diet for everybody. And I think patients are under the misconception that when you are prescribed a renal diet, you follow it for life. But as we all know, that's not the case. And it's good to remind people of that every time you see them, that maybe there's a change in the prescription because something about their treatment has changed or their disease has progressed. So the first step in my head when I get a referral for a patient is to think about what stage of kidney disease they're at. And to do that, you need to have a look at the blood test and you need to have a look at the urine. So for somebody like Mr. G, who I think I said was 55 mils per minute, yes, so he fits into this category here of 3A. over here. And then the next important contribution here is how much protein does he have in his urine? And if we look at this kind of famous grid of how to categorize people's risk of progression of their kidney disease, he actually fits into this category here, which is the orange category. So what that means is he has sufficient protein appearing in his urine for it to be a problem, and he's at moderate risk of the disease progressing to kidney failure. Now, the reason that you may be wondering why that's of interest to dietitians is because when you get people who are in the nephrotic range of protein, so on the side of the screen there, I've got an indication of what that might be. So it's around 3 grams per 24 hours. We actually have to add additional protein onto that dietary prescription to compensate for those losses. So you don't want to add too much. You want to add roughly the equivalent amount of protein onto the dietary prescription once they've exceeded that 3 grams per 24 hours. But in this case, Mr. G has not, so he doesn't need additional protein above and beyond the evidence-based guidelines amount. So the next step then is to also think about the 7 functions of the kidney. So for Mr. G, if we're having a think about the 7 functions of the kidney, we may want to see and seek and check out if he actually has had any vitamin D tests done lately. We want to check his acid-base levels, and at that level of kidney function, it's probably likely to be okay, but it's good to check nonetheless. And part of the reason we want you to do that is just as a reminder that the kidney excretes hydrogen ions and also is responsible for excretion of bicarbonate and manufacture of bicarbonate. So when your kidney declines in function, you have an accumulation of protons or acids, and therefore that contributes to metabolic acidosis. The other functions of the kidney are to control electrolytes, and for somebody who's at stage 3A kidney disease, he's unlikely to start seeing hyperkalemia or hyperphosphatemia, but it's worth checking. The other thing that's important is that kidneys are responsible for the degradation and excretion of hormones such as insulin. So it's a very common scenario for somebody at this particular stage of kidney disease to say things like, I've started having hypoglycemic events again. I've had diabetes for 25 years and now suddenly I'm having hypos. And that's because your kidney function has started to decline, that insulin hangs around a little bit longer, and therefore you're more susceptible to having hypos. Just going through the other functions, elimination of nitrogenous waste. So you'd want to check the urea levels. Having a look at fluid balance may also distort some of those other electrolytes that are found outside the cell and are affected by hydration. And then we have the production of hormones such as EPO. So we would like to check his hemoglobin levels if those blood tests are available. So that's the checklist that I go through in my head when I'm collecting information about the patient before I start the dietary prescription. And the other thing that I do is to also think about what might be the signs and symptoms that you would expect to see a patient talk about, or at least provide some commentary about if you ask them. So when it's stage 1 or 2, you're very unlikely to have a patient describing anything other than perhaps if they've got heavy proteinuria, they might see that their urine looks frothy. But as you progress through the stages of kidney disease, of course, the symptom burden increases. So for somebody like Mr. G, who's at stage 3A, he may not necessarily feel any different, but maybe perhaps has a little bit of nocturia, getting up at the middle of the night to wee more. Or maybe some mild swelling might have been noticed. It's actually worth spending the time to go through these symptoms with patients, because often it creeps up on them so slowly that they may not actually realise that they're experiencing these symptoms. It may just be an accepted norm and they've had it for 2 or 3 years and they forget that they actually have taste changes or chronic nausea, or maybe they've got drowsiness at particular times of day, or the skin changes and so on. So this list of symptoms here has a big impact on the nutrition prescription as well. So finally, step 3 is to think about constructing your diet prescription. So after you've had a nice conversation with the patient and you've gathered your history, you can then start putting together the modification of the nutrients. But one thing I just wanted to point out for you is this particular diagram here is adapted from something brilliant from Cam Kalantazadeh, who's published this particular document in the Lancet. But essentially, there's 2 rules or purposes of medical nutrition therapy in chronic kidney disease. The first one is, in the early stages, what we're focused on there is the nutrition prescription is being used to help retard the progression of the disease. And by doing so, you're controlling all of those lifestyle risk factors. So if they're overweight, your goal is to reduce weight through the dietary therapy. to control their blood pressure, to control their blood glucose levels, and if they've got gout, to control their uric acid levels where possible through some dietary changes. But as you progress through the stages of chronic kidney disease, the focus of your medical nutrition therapy prescription changes to one where you're actually managing side effects of the disease and also the treatment itself. So if they were to undertake dialysis, you need to also manage the side effects of those therapies themselves. And I think sometimes it's helpful to kind of categorize and understand that that's the purpose of medical nutrition therapy. So then we start constructing the nutrition prescription. And this is a summary diagram that I put together, and I carry this around with me in my stuff when I go and see patients. And basically it's the Bible that I go by. And it's a combination of a summary of information from the KDOQI guidelines for chronic kidney disease released in 2020. And the areas that are particularly relevant are shown in red here. So what's changed since 2020 is that the amount of energy has actually dropped a little bit. So it's only 25 to 35 calories per kilo now in people who are metabolically stable across all of the stages of chronic kidney disease. The parts in red about protein are also new. So for example, for somebody on dialysis, it's now 1 to 1.2. The part about protein for people who are stages 3 to 5 is a little bit controversial because it's actually quite low and very difficult to achieve in practice. So the clinical practice guidelines now state 0.55 to 0.6 grams per kilo if you don't have diabetes, and if you do have diabetes, it's up to around 0.8 grams per day. The part that's shown in purple there is actually the new clinical practice guideline that was produced by KDIGO, released this year for management of chronic kidney disease. And they don't actually recommend going down so low. They actually suggest 0.8 grams per kilo for everybody and avoiding high protein intakes for people who are who are stage 3 to 5 kidney disease. So in practice, we're probably aiming around somewhere like 0.8 grams per kilo for somebody like Mr. G. And then we would make sure that they have a diet that's low in saturated fat. We would have a look and do an assessment of their fluid. And if they're on diuretics, make sure that they're not having excessive intake, making sure they meet the targets for fiber. And if I move on to the next slide here, the parts in red are actually taken from the 2020 guidelines for chronic kidney disease. And they're actually a little bit more challenging in practice because we actually have less guidance when it comes to managing potassium and phosphorus. And they actually state to reduce the intake of those foods as low as you can get that blood level to come down to, and making sure that if they're on dialysis that you're reducing, say, calcium intake from all sources to around 2 grams or less per day. What's most important and has changed with the guidelines since 2020 is a really important focus now on the quality of the diet, not just the focus on the nutrients. So we really want people at all stages of chronic kidney disease to be having adequate fruit and vegetable intake, making sure that those foods contribute to improving net acid production, and making sure that we have healthy, diverse diets with an inclusion of plant-based proteins in the diet where possible, and using renal dietitians or nutrition specialists to help provide that education because it is a specialty area of practice. So that's been a really important shift and focus, and that's what our education should be focusing on. So if we go back to Mr. G as the case, what would we suggest? Well, in my opinion, we would suggest a diet with adequate energy, so 25 to 35 kilocalories per kilo, or use your clinical judgment to adjust that if there are other reasons why you think they may not be metabolically stable. Probably around 0.8 grams per kilo, and if they're overweight, it might be an adjusted body weight that you use. Having a no added salt diet and making sure they use reduced salt packaged products if they're available. Low in saturated fat, and making sure they get adequate dietary variety, particularly with a focus on getting intake of fruit and vegetables and having smaller serves of protein-rich foods and dairy. So why is there such a focus on protein? Perhaps nobody's ever really explained this in great detail, but there is really good evidence about why we need to focus on protein for somebody like Mr. G. And that's because all the action is happening here in the glomerulus. And when you've got a person that's eating excessive protein at this stage of chronic kidney disease, what that does is it drives hyperfiltration. And when you've got increased hyperfiltration, it actually causes dilation of this afferent arteriole in the glomerulus. And when you've got extra blood flow coming into the glomerulus, it actually increases in the Bowman space the glomerular pressure. And unfortunately, the efferent arteriole doesn't dilate to accommodate for that. So you actually have high amounts of blood coming into the capsule, but you can't push that high volume of blood out. And so you have increased glomerular pressure, and that can cause scarring and damage. And that's what causes a decline in kidney function. And there's another example of that. So why is there now also the focus on diet quality? Well, this is because of fairly recent large epidemiological studies and systematic reviews that show that dietary patterns are really important. It's not just the nutrients. So diets that are high in fruits and vegetables, legumes, nuts, and whole grains are really important. And having an intake that's low of sugar-sweetened beverages, processed meats, and salt. They're all associated with the things that we want to happen. So having less incidence of chronic kidney disease, having less problems with albuminuria, and having a lower mortality. So that's why we want to focus now on the combination of foods that people eat rather than just the nutrients. So in Australia, this is a summary of what we would suggest to people with chronic kidney disease. And I'll just explain some examples here. So if we look in the category here that's labelled fruit, we recommend that everybody, regardless of your stage of chronic kidney disease, consumes 2 serves of fruit every day. And in Australia, a serve is roughly equivalent to what you fit in the palm of your hand. So we're basically saying to people, you need to have 2 handfuls of fruit every day. When it comes to vegetables, the same rules apply. All people with kidney disease should be consuming 5 serves of vegetables per day, even if they have a history of hyperkalemia. What you can then do if they've got a history of hyperkalemia is manipulate the sorts of vegetables they're consuming, but we don't want them to cut vegetables and whole food groups out. We want them to have 4 to 6 serves of breads and cereals every day, and in Australia that's equivalent to roughly about half a cup of rice or pasta and a slice of bread. And in terms of meats and alternatives, this is where it's slightly different, and you'll have to use your clinical judgment. We want people to have less protein serves in stage 3 to 5, but when they have dialysis, have more. And as a general rule, we want people to only have 1 serve of dairy products per day for stage 3 and stage 5 dialysis. And that's because the phosphorus and the calcium contained in those dairy foods is too excessive. And it's also a food that contains potassium. So for example, if you're drinking milk, and so 1 serve is equivalent to about 250 mils or 1 cup, or maybe 30 grams, 40 grams of a slice of hard cheese. Again, we want to limit discretionary food items such as chocolates, lollies, soft drinks. So this is the dietary pattern that we suggest to all people with chronic kidney disease, and then we manipulate the nutrients as a result of that. So this is the sort of diet we want to be focusing people on, one that has diverse colours, diverse ranges of fruits and vegetables. We no longer pick on some of the food items in here. So traditionally we would have said, oh, no tomatoes, no apricots, no rock melon, no kiwi fruit. All of those things are fine to have if you're eating appropriate quantities and portions of those foods. So let's move on now to another case, which is Mrs. L. And she has been referred to you because she's been on dialysis for a couple of years, but she's having some troubles. She weighs about 75 kilos, so not a bad weight. Her interdialytic weight gain is about 5 to 6 litres, so it's actually excessive. And roughly we want people to gain no more than about 1 kilo in between those dialysis sessions. Her blood glucose control has been poor, and her potassium has been periodically high, and that's related to her poor blood glucose control. So what would be the dietary prescription for somebody like Mrs. L? Well, let's go back to thinking about the stage. Well, she's already on dialysis, so she fits down into this category here, down the bottom. We're thinking about the 7 functions of the kidney. So we would want to check, is she having vitamin D replacement? Because she should be if she's on dialysis. What's her acid-base balance like? Is she struggling with metabolic acidosis? And that's probably going to be something that's a problem for her. And that can be adjusted with the dialysate, but it may be that she also needs to take, at least in Australia, it would be common to take sodium bicarbonate capsules. She's definitely going to be having trouble managing her electrolytes, and she's already had evidence of problems with potassium control, but we'd want to look at the other electrolytes, which are likely to be abnormal there. So potentially looking at her calcium and her phosphate. Check and see, does she take insulin? What's happening with her blood glucose levels? How are things going there? What's her urea level like? Is it excessive? Is she having adequate dialysis? Is that making her feel sick because she's not getting adequate hours, or perhaps there's a problem with the flow in her fistula. Having a look at her fluid balance. So is she at the right dry weight? Is that the problem as well? We're not actually dialysing enough off her every time she comes in. And then making sure she's getting EPO replacement therapy of some kind and that her iron stores are okay. So the 7 functions of the kidney are really important to go back to make sure that you're collecting all the relevant information for your assessment. So in this case, we would ask her lots of questions about the nutrition impact symptoms. So does she struggle with fatigue? What about nausea and vomiting? Does she have cramps, pain, skin taste changes? All of those things would be essential for us to do. And then we would start thinking about what's the actual physiological processes on dialysis that we need to take into account when we do the nutrition prescription. And in case you've never had that explained to you, here's some of the examples of why the nutrition prescription is slightly different for people on dialysis. So there is a physiological limit to the amount of fluid that can be removed per hour, and it's roughly the rule of thumb of 13 mils per kilo. So in somebody like her, that's about 975-ish mils per hour. But we already said that she's coming in with 5 to 6 litres. So unless she's doing long hours of dialysis, there's no way that one dialysis session is able to remove all that fluid. There's also significant macronutrient losses such as protein and glucose. We also have potassium removed in the dialysis. So it's important to think about what strength potassium bath is being used. Phosphorus is removed, and also there's losses of water-soluble vitamins. So what that means in practice is we need to think about, well, is she doing enough hours of dialysis to remove all the fluid that she's coming in with? And in this case, probably not. Is she eating at adequate amounts to replace the protein that's lost in every dialysis session? And if it's a 4 to 5 hour session, it's around 8 to 12 grams of protein that's lost and 25 grams of glucose, which in my head is about 2 slices of bread. There's also potassium losses. So this is a variable amount that depends on the amount of glucose she has in her blood, the amount of potassium that's in the bath that's being used, and how high she's coming in. It's also important to remember that the phosphorus that's lost during a dialysis session is actually not that substantial, to be honest. It's only 600 to 1200 milligrams per session, and there is more loss in that first 2 hours. And there's also a need to make sure that she gets adequate replacement of those water-soluble vitamins. So that's why the nutrition prescription is slightly different. So if we put that together, we need adequate calories, 25 to 35 calories per kilo. We need 1 to 1.2 grams per kilo of protein, including vegetable or protein that comes from plants. And we want to make sure that she's getting down to adequate amounts of fluid being removed. We want to make sure she has a no added salt diet, make sure that she's consuming adequate amounts of plant foods, but also that we've given her advice if her high potassium is related to her excessive intake, then we might need advice, but I suspect in this case it's probably related to acidosis and poor glucose control, and making sure that she's reducing her phosphorus levels. So in this case, we still want to recommend adequate fruits and vegetables, adequate variety of foods. And so if we come back to the question, what is the dietary prescription for this person? It would be making sure that we control her excessive interdialytic weight gain. So talking to her about a diet that's reduced in fluid, but also figuring out what's driving that excessive thirst. And it's probably the poor glucose control. So we would talk to her about making sure that the carbohydrate is not excessive in the diet. We would make sure that she's also got adequate salt, so not excessive amounts. We might think about some potassium and phosphorus modification, and making sure she has adequate diet quality and is not getting constipated. So there's quite a few things to go through with a person like this. And one of the problems is it can actually be very overwhelming for a person to make all of the changes that are required. So it's important to scaffold the dietary advice to prioritise what's the most important issue today, and maybe only focus on a few of them and the most critical ones. So in this case, we might want to focus on sodium intake and fluid. And if it was just as simple as maybe they weren't taking their insulin or their diabetes medications, making sure that that's happening, making sure they're not eating excessive amounts of dairy foods. And that's because not only are they a source of phosphorus and potassium, but they're also going to be a source of fluid if she's drinking large amounts of milk. And then we would go through the other things that need to be modified in the diet of somebody like this. But the most important part in my mind is that we talk to people in terms of foods rather than nutrients, because it's much easier for people to make behavior change if we're talking about practical things like food rather than nutrients. So here's the suggested plan. Make sure she controls her blood glucose levels, because that will help with thirst and the management of hyperkalemia. If she's taking phosphate binders, making sure she's taking them at the right time with the right foods. And is she getting adequate hours of dialysis and the right dose? Making sure she's not constipated, because that will also contribute to hyperkalemia. And making sure you have a bit of a check of, has she had any previous dietary education before? Because maybe she's under some misconceptions about what she should or shouldn't eat, and maybe they can be relieved or alleviated or changed and updated. So it's important to catch up with her previous education there. These are the common questions that I get from people who are new to the field of dialysis. So can't I just eat what I want because high hemodialysis is just going to dialyze it off anyway? Well, unfortunately not. And I showed you some of the physiological capacities and problems. So we can only dialyze around 900, mils in this case per hour. You can only get rid of 600 to 1200 milligrams of phosphorus. And if your phosphorus intake is excessive and your phosphorus level in your blood is high, one dialysis session is not going to fix that. Hemodialysis patients are catabolic and they need more energy. Well, the evidence is actually no, that's not the case. Why do dialysis patients need more protein? Well, the answer is because they're getting protein losses from the dialysis procedure itself, and we don't need to restrict phosphorus in those on binders. Absolutely not true. Skip through that, and this is why. So if we go back to the first principles, dialysis removes 600 to 1200 milligrams a day, and something like calcium carbonate, which is around 6 tablets per day in Australia that they can take, is really not going to remove that much. So in total, you might get removed 2700 milligrams per week from dialysis plus binders. But in Australia, at least, we know that most people's daily intake of phosphorus is 2000 milligrams, and they absorb 60% of that. So that's 8,400 milligrams a week. So the balance is definitely tipped a lot in the favour of having excessive accumulation rather than removal of all of it during dialysis. Let's move on to some competing priorities now. So this is a common one that I get from dietitians who are having patients that come onto their hospital wards that have kidney disease, but they're not there for their kidney disease. So for example, Mr. M has diabetes and he's had a recent debridement or cleaning of a severe wound, but he's also got stage 3B kidney disease, and people panic. Let's have a think about why that might be. Well, if we have a look at the guidelines for somebody with stage 3 kidney disease, they need adequate calories. If they've got diabetes, then they are around 0.8 grams per kilo. And we want them to make sure that they're not drinking excessive amounts of fluid, because it's likely that they've got some fluid buildup and edema there. But that's in contrast to the evidence-based guidelines about wound healing, which actually encourage extra calories, extra protein, and extra fluid. So what do you do when you've got somebody with competing evidence-based guidelines who are quite different? Well, my rule of thumb or rule of fingers is to think about these 3 questions. What is the condition that is most urgent or important? Does treating this condition create more complications? And if it does, can these be managed or tolerated? So if we go back to the case of this particular person, I don't know where number 1's gone. What is the condition that is most urgent? Well, in this case, it's fixing and making sure that the wound heals adequately. So does treating this condition create complications? Well, if we're treating it with medical nutrition therapy, it may, because there's a temporary increase in protein. And as a result, there's also going to be an increase in potassium and phosphorus intake. We may also see a temporary rise in urea, and you may also need extra fluid to replace the fluid that's lost through the exudate of those wounds. But this is something that can be managed and monitored and tolerated. So in this case, the priority that comes first is the wound. The nutrition-based guideline that comes first is the wound-based one, and the CKD can kind of be on the back burner until the wound is healed. Let's move on to the second competing priorities case. So we've got Mr. H here, and he's been seen in the clinic by perhaps one of the nephrologists. He's been identified as being malnourished, but he has stage 4 kidney disease. So what would somebody like this be in terms of his requirements? Well, let's go back and have a look. We know what they are, 25 to 35 calories per kilo, a reduced amount of protein, and we want to monitor the fluid. But if we look at the guidelines for the management of malnutrition, it's actually, again, higher in calories, higher in protein, and higher in fluid. So what would we do here? Well, in my opinion, think about those three questions again. What is the condition that is most urgent or important? Does it create complications, and can they be managed? So in this case, the problem that needs to be fixed is malnutrition. And that's because once you start on that spiral of being malnourished, it's very difficult to come back from that. And we also know that if people are malnourished when they start dialysis, they have much worse prognosis and a shorter life expectancy. So in this case, we want to treat his malnutrition. So he may actually have a longer term course to fix that. It might be 6 to 12 months perhaps, but we want to make sure there's adequate protein. But to do that, we're also going to subsequently increase potassium, urea, and fluid to manage that. So again, can this be managed or tolerated? Yes, and maybe you might discuss with this with the doctors in the team and just let them know that in order to treat that malnutrition, you may need to temporarily increase protein, which might see some temporary increase in their urea or their potassium levels, and not to be kind of concerned. You may also want to get some advice from the treating doctors about what they think might be an appropriate fluid intake for somebody who might be in this scenario, because that's a complicated thing to work out, and I'd always be guided by the doctors in the team. So just to sum up, just running to time here, my purpose here was to guide you as to my rules about how to figure out what the basics of renal nutrition are. And so it always comes back for me to letting the eGFR and the urine results guide you so that you can categorize the patient and figure out if there's any additional protein that you need to add on to your prescription. Going back and thinking about what the functions of the kidney are, so that when you do your history taking, you're doing it in a targeted fashion. You're searching for information that may not be necessarily available, but you have to chase it, and having a think about whether it should be abnormal for somebody at that stage. And remembering to remind the patient that the dietary prescription will change over time, and that you need to frequently catch up with that person as their treatment changes or as their condition may change, so that they're not following outdated advice that might actually compromise their health in the longer term. So I think I'd like to just perhaps cease the presentation here, and if people have any questions, I'm happy to take those questions now.
Kelly, that was quite an enlightening discussion, and with very good case scenarios. I'm sure we have learned quite a lot on that. Just to the participants, the Q&A chat box is open. You can post your questions. And for the panelists, feel free to unmute yourself and ask your questions live. I believe there are a few questions that have already been posted. If I can just read some of them. So the first one is from, I believe, Dr. Mfuru, who's asking about how can we implement the nutritional management in lower middle income countries where the caloric calculations is not always done or it's not practical. Yeah.
So I think in that case, especially if you're not a dietitian, it's always to go back and think about, are people eating what we call in Australia the core food groups? So are they getting adequate serves of all of the different food groups that you want them to get? And I know, at least in Australia, that if you are eating those core food groups of adequate fruits and veg, breads and cereals, meat and protein, and dairy foods, for an adult with CKD, that roughly provides around 7,000 kilojoules per day. So unless they're a particularly short, small, petite person, that's not likely to be adequate calories for most adults. And so you need to make sure that they're making that up with extra fat and extra sugar if that's appropriate. Hopefully that answers the question. So I'm not expecting everybody to be able to do that maths and those calculations, but it comes back to, are they eating an adequate variety and volume of food? That's what I think anyway.
Thank you for that. I think for the next question from a participant by the name Elizabeth is asking for protein quality in Mr. G. I believe that's one of the case scenarios. What would you recommend more between plant and animal protein?
I actually think there's more and more evidence suggesting that plant protein is actually superior. So if you can get people to eat more plant protein, do so. And that's also partly because that enhances the acid-base balance as well. So they're still going to be able to get sufficient amino acids, but the other added advantage is it helps balances metabolic acidosis as well. So any legumes, nuts, protein you can get from grains, I would go for those. That would be fantastic.
Thank you. Another question from a participant by the name Jeriah asking, what about selenium additions? Is there a risk for vitamin C regarding increase of calcification in CKD or dialysis patients?
Yes, that's a good one. Selenium is dependent on the quality of the soil, but it's also likely to be removed. So I would suggest that a multivitamin that contains selenium should be okay, taken after dialysis if it's for a dialysis patient. What was the second part of the question there? It was about vitamin C, was it? Oh, sorry, Yuri, you're on mute.
Oh, sorry, yes. They were asking about, the question was on, is there a risk from vitamin C additives regarding increase of calcification in CKD or dialysis patients?
Okay, so in dialysis patients, vitamin C is lost during the dialysis session because it's water soluble. As far as I know, it's not connected to vascular calcification. It's more about oxalosis. So I don't think, unless they're taking mega doses of vitamin C as replacement, that would be a problem. But if you're just taking the recommended daily allowance of vitamin C as a supplement, that should be sufficient. And take it after dialysis. I hope that answers your question. I apologize, I didn't read it quick enough.
I believe that answers the question. For the next one, there's another question by a participant called Lucas. Question is that in many hospitals, they are only general nutritionists. What is the future plan to equip them in managing CKD patients' nutritional status?
Oh, that's a good one. I think it's always worth, whatever specialty area, whatever ward you work in, to ask the two most important questions. How is your appetite and have you lost weight recently? And then, I mean, that's an important general screening kind of a tool for people who are working as nutritionists in hospitals. What is the plan? I don't know in Africa what the plan would be to upskill. That's a good question. I don't know. At least in my area of the world, we have shadowing programs where you can follow experienced renal dietitians, but we also have specialist renal nutrition training programs where you can come and get some additional training that's covered. I don't know if that answers your question, though. I'm afraid I don't know enough about plans in Africa. Yeah.
Yeah, I think that's a challenge to us. And again, in terms of policymakers, to ensure we have programs running for that. There's another question by Dr. Jacqueline Shu. I believe Dr. Jacqueline is one of our panelists. Maybe Dr. Jacqueline, you can just unmute and ask your question live.
Yes, thank you for a very nice presentation. My question was, I was very impressed that it seems like patients are having these personalized plans. It's not like one fits all, and which is very good. And what I see from our side is a very big challenge. So you find that for us, we have one paper that says, don't eat this, or eat this and eat this, and this is for everyone, which I find it very difficult for patients to abide. So how do you manage this? Do you have specific teams for kidney patients that you will be following them, or is anybody will see them?
Yes, in Australia it is common to have specialist renal dietitians that see people from pre-dialysis stage. So for example, where I worked, it was routine for everybody who had a GFR less than 30 to see the dietitian. It was a routine referral. But we did see everybody at all stages of chronic kidney disease, and that's not uncommon across different Australian units. I think that the problem that we struggle with is the volume of patients that need to be seen is just so huge that people don't get the number of appointments that are required to see all of the different changes in behaviour that are required to keep them healthy. So we do have a range of resources that are common and are shared amongst renal dietitians in Australia, and they generally all have the same message, which is make sure you have a good base diet that has 2 serves of fruit, 5 serves of vegetables, 4 to 6 serves of breads and cereals. If you have this stage of kidney disease, say 3 to 5, make sure you only have 1 serve of dairy. Make sure you only have a palm-sized piece of meat, chicken or fish. We're all singing from the same hymn sheet about that message. But then we also have that if you are able to, please contact your renal dietitian for more individualized advice. So I don't know if that answers your question, Jacqueline, but I do appreciate that a one-size-fits-all approach is not appropriate, and that's where people get into a tangle, I think, or their dietary advice doesn't change as their situation changes. That's a problem for people.
Yeah, thank you very much. I think the other challenge for us, for example, in Tanzania, there's a problem of having a guide that contains food, what the food contains. So, and the portion, understanding portions, like how many portions per day, because for us, there are a lot of challenges. Having 3 meals per day may be difficult for many of our families here. So I think that the need for us to collaborate with centers and experienced personnel like you and others, then we see how we can develop something. And because that dietary restrictions and is a very it plays a very big role in reducing the burden of CKD. For us, we cannot afford to have everybody on dialysis or on transplantation. So I believe the role of dietary intervention has a very big room, and I think Dr. Lloyd will help us and see how we can proceed in this to make sure that we use people like you to make ourselves better in this area. Thank you.
Absolutely. Thank you.
Thank you for that. There's another question asking what will be your recommendations, or will you recommend plain vitamin D supplementation or a combination with calcium for supplementation?
In Australia, our scope of practice doesn't allow us to make dietitians to make recommendations about vitamin D. That sits solely with the nephrologist, so I won't answer that part. In regards to calcium supplementation, we don't use calcium supplementation apart from as a phosphate binder, and it's usually calcium carbonate on its own, 600 milligrams, 2 tablets, up to 3 times per day. That would be a typical binder dose. Once that's, trialed and it doesn't seem to control phosphorus levels, then we would move on to other types of binders, but that's the first line therapy. We don't recommend calcium supplementation for people for bone health. It's about controlling the phosphorus. That's what controls your bone health. Hopefully that answers your question.
Thank you. Another question from one of our nutritionists by the name Juma Msuya. Is asking, how do you manage protein energy wasting / malnutrition for the patients on chronic hemodialysis while avoiding the refeeding syndrome that occurs sometimes?
That's
or
a
at the
really
same
good
time,
question.
Yes.
Yes, it can happen. So we are aware and we do look out for and screen for potential refeeding syndrome. I think in practice, it's really challenging. And we use whatever means necessary to help people get the calories that they need. But we, in general, would start with making sure that they try food-based therapies first, mainly because it's affordable. So it might be enriching the sorts of foods that they're eating with extra fat or extra sugar, or if they can afford it, perhaps things like milk powder added to things. We would then escalate that if that's not working to using commercial oral nutrition supplements. But in Australia, those things are quite expensive. So most people aren't inclined to take them, although most dialysis units in Australia provide those for free to patients. The problem is they're still only getting them 3 days per week. The other strategy that I have used in the past for a select group of patients is using intradialytic parenteral nutrition to also top up that person with additional calories when they're coming into dialysis. But that's not for everybody. And enteral feeding is really rare in people who are suffering from protein energy wasting. In my experience in Australia, it's very hard to get doctors to put tubes in, but in theory, that's probably the best way if they can't get adequate intake. just going back to your refeeding syndrome, I know it's potentially possible, but I haven't really seen it happen very often. But I work in a different setting to where you guys are. So it may be that you see much more pronounced and profound alterations in those electrolytes in the absence of maybe IV thiamine or whatever you might choose to give. Hopefully that
Yeah, I
answers your
think
question.
we do have quite a number of nutritionists online, so there are quite a number of questions coming
Good.
in. I hope you're okay for time. If you
Yes,
can
that's
just go
fine.
through a few more. All right.
Yep.
So there's another question just asking on what you would suggest, whether IV or oral vitamin C supplementation regarding to the absorption or oxalate in the gut.
We don't ever give IV vitamin C supplementation. If we did give it, units would normally give oral vitamin C, and maybe only 3 days a week, for example. In terms of the oxalosis, that would be kind of dealt with by people taking the calcium supplements as phosphate binders, because calcium will bind some of that oxalate as well in those patients. So that will reduce the risk of potentially calcium oxalate kidney stones. Yeah, so hopefully that answers your question about the vitamin C there.
Just another question asking whether it's advisable for CKD patients to take nutritional supplements.
If you mean nutrition supplements in the forms of vitamins, then potentially yes, if they're at stage 4 and 5 and their oral intake is poor and it's been sustained at a very low level for a long time. So they would be potentially at risk of zinc deficiency and other vitamins. We routinely supplement people in Australia with water-soluble vitamins if they're on hemodialysis. And I can tell you that we have just written the new guidelines for nutrition supplementation for people undertaking peritoneal dialysis. And in essence, when it's published, it will basically say, if you do have a person who you think is at risk of nutrition deficiencies and they're doing peritoneal dialysis, then you just supplement at the RDA level, recommended dietary intake level. But that's probably going to be released in around June this year. So if you do have patients on PD, stand by. But yes, routinely we do supplement water-soluble vitamins.
Knowledge in nutrition, how can we make it applicable? Because telling someone to take about 25 to 35 kilocalories per kg is difficult to understand. I think you had mentioned about portions at some point. Maybe you can just go
Correct.
back on that.
Yep. Could you just repeat the first part of the question? I didn't hear it. Sorry, it just cut out for me.
Oh, sorry. I think my bandwidth is a bit low, but the question was that in the African context, where most of the people do not have enough knowledge in nutrition, how can we make it applicable? Because telling someone to take about 25 to 35 kilocalories per kg is a bit difficult to understand. I think you had mentioned it at some point in terms of portions that people can also
Correct.
take. Maybe you can
Correct.
just highlight more on this.
Correct. So I know so that is dietitian speak, 25 to 35 calories per kilo. We'd never talk about like that with a patient. But what I would explain is that if you don't have the capacity to eat that volume of food that I described before, so 2 handfuls of fruit, 5 handfuls of vegetables, a range of different breads and cereals, having some portion of meat and having some dairy, and in addition, can you have around 50 to 60 mils of oil or butter or fat per day? Then that's likely to mean that they're not reaching that level of calories per day. So they would need some enrichment of the foods that they do eat. So it might be that you ask them to add extra fat or extra sugar, or if they can afford something like milk powder to enrich the foods, then you would use that as a strategy to help them reach that 25 to 35 calories per kilo. But essentially, if they can eat more, encourage that. If they can enrich what they currently eat, encourage that. And if you can get them to add fat as the preferential source of energy, do that. It's obviously more effective that way. I do appreciate you have lots of challenges in Africa that we don't necessarily have here in Australia.
Thank you for that question. I think there's a participant asking whether they can access the slides. Maybe if I can just answer this. Later on, we'll be posting this video on our YouTube channel, so I'm sure they'll be able to access it from there.
Can I just answer that last question I see here about intraperitoneal amino acid dialysate solutions? So if you're not aware, That's a solution that contains around 18 to 20 grams of protein, and that's used as the osmotic agent. They're not actually effective at improving nutritional status. They still need to have adequate calories, but you do passively absorb some of that extra protein. But if you're not getting extra calories, that extra protein will just be utilized as a source of energy. So unfortunately, most of the clinical trials that have tested that have shown that it's not effective. And I suspect that's because people weren't getting adequate calories to start with. So they're quite expensive, and they're not as effective as glucose-containing dialysis solutions anyway. So thank you for that question. Yeah.
Thank you for that.
Yeah, a fantastic presentation. And indeed, I think, like, as you realize from the questions, nutrition is such a big issue. So far as the management of kidney diseases in our part of the world, starting from the fact that we don't have the required human resource. And personally, from my experience as a nephrologist, when I send them for nutritional counseling, they actually come back worse because they give them, like we mentioned, those clear cuts, one size fits all. And you might have a patient probably who has a good residual renal function, eating probably about 1 liter or 1.5, and they tell the patient, so restrict your fluid without asking clearly what do you think. And then in terms of, as a nephrologist, you have a fair idea of what their albumin is, and you're encouraging them to probably take a bit more protein, and they go their respective. So it's really a huge challenge. But at least as for your presentation, you try to give us some practical steps, which I believe people on the call will take note of. And for those of us who don't have clear renal dietitians, we probably have to own the space one way or the other by helping to improve their capacity to be able to help our patients. So it's just a comment, not a question. Thank you very much for your presentation.
Thank you. Yeah, very challenging. Yeah.
Thank you, Professor Kelly, for this interesting talk. I think it was really, really enlightening, and you've really tried to guide us through how to go manage a patient and meet their nutrition requirements. I do understand that we are really having a big shortage of nutritionists, and whenever we have them, they are not really trained in CKD. So oftentimes, then dialysis nurses and the nutritionist and the nephrologist are always shouldering the task of treating the patients and giving them dietary advice, which is challenging. Wow. So I really think that it was a very, very interesting talk for that. Thank you so much.
Thank you. That's a big load you have to carry.
Thank you for your very, very nice presentation. I just have one question regarding to the NP nutritional per dialytic, intravenous nutrition per dialytic per dialysis. What about your opinion regarding to that for patients with malnutrition, and you have a problem to propose for them oral nutritional support?
Yeah, so in Australia, we can give intradialytic parenteral nutrition to anybody, unlike in the United States, which is kind of bound by different rules. And in practice, we have two different solutions we can use. We can use a triple phase bag, which has carbohydrate, fat, and protein, or we can just use lipid only. And I guess there's two schools of camp. There's some people that only ever use lipid only. And my opinion is that would be suitable for people who just are lacking calories but can get adequate protein. But in my experience, most people who are malnourished would also be not eating adequate protein and adequate calories. So that's why we chose to use the triple phase bags, because the person would get extra carbohydrate, extra protein, and extra fat. But in practice, when you work it out, it's really only getting about an extra 2,500 kilojoules a day averaged over a week when you give IDPN 3 times per week. So they do need to be having a fairly substantial amount of kilojoules each day, and IDPN just tops them up. But you could also add some oral nutrition supplements to that and some other dietary counselling, and it might be just that combination of things gets the person over the line to getting adequate calories and nutrition every day. But it does require a specialist nursing expertise to administer it, because it's an extra line that's going in. And in some patients, they've already got a lot of lines. They might have antibiotics, they might have iron solutions or whatever it might be. So it may not always be appropriate, but it certainly is effective when you have the right patient. I guess the problem in Australia is always it's often left as a salvage therapy too late when the person's consuming virtually nothing, and it's not going to save them at that case. It's because you're only getting 4 to 5 hours worth of solution 3 times a week. So it's not worth it in those circumstances where they're virtually eating nothing. And it's effective when you get the right patient. So I hope that answers your question.
Yeah, thank you. Thank you so much for that.
Thank you.
Can I ask another question, please?
Mm-hmm.
Yeah. Please regarding to the magnesium, because there's a big problem regarding to that for the people who have cramps and we don't have anything out of maybe neuropathy, but we are not sure. We treat this, but they still have cramps. And what do you think? Because you use about 0.5 magnesium per liter at the dialysate, but we can increase it at 0.75. However, for the oral supplementation, do you think that this can be done in dialysis patients regarding to the risk, because you don't check well magnesium? Do you think that it is interested to give them magnesium even if we are not sure regarding to magnesemia for these patients?
Yeah, I know what you're asking. Is it in relation to cramps? Is it worth the risk? Is that what you're asking? Should we give magnesium? Look, it's worth a try, but we would also review how much fluid's coming off, what their sodium's like. We'd have a look at their dietary intake. There's all different kinds of home remedies that people use, but in terms of magnesium, maybe it would help if you adjust the dialysate or you give the supplement. And if you go too high, well, at least you could monitor it, and maybe it'll help their bowels if they've got constipation. So it's worth a try, I think. It must be excruciating, I think, to have that problem.
And what would you suggest? 100 milligrams per day or 300 milligrams per day?
I'd probably go 300. That's only equivalent to a glass of milk, so it's not that much. You'd probably need to bump it up a bit. Yeah, maybe even 500. I don't know what dose sizes they come in Africa, but 100's not very much. Yeah.
Okay, thank you.
Give it a shot. Yeah.
Thank you. I think there's Dr. Frida. I think she's put her hand up. I think she probably has a question. Dr. Frida, you can unmute.
Thank you. Thank you, Professor Lambert, for the nice presentation. As my other colleagues have said, it has really enlightened us. And nutrition in Africa is a challenge part due to scarcity of nutritionists, especially those who are expertise in CKD. So I just wanted to ask, like we have patients who are diabetic and others who are not diabetic in CKD. And it's really a challenge because most of them are being prescribed with one size fits all. And it's challenge, especially in diabetic patients, to adhere to the so-known CKD diet. So maybe when you're sending your PDF for the slides, can you add some materials which will guide us also in patients who are diabetic and non-diabetic, how to differentiate among them? Yeah, thank you.
I can do that. No problem. Thank you.
Thank you so much.
Lovely.
Thank you for that. Professor Kelly, maybe if you're okay to just take 2 last questions.
Sure.
I just don't want to lock out anyone. So
That's
from
fine.
one of our nutritionists by the name of Juma Msuya is asking, how do you address the challenge of managing fluid intake in patients on maintenance hemodialysis, particularly in cases of fluid overload or inadequate fluid removal? And I can just add a follow-up question on that, my own question, because I've had certain patients being advised to either nibble or take ice. I know in areas, we have coastal areas that are quite hot, either in Kenya and Tanzania. I don't know whether this is okay. It's okay to practice that, or it's probably you can just give your take on it.
Sure.
All right, thank you.
We struggle with the same problem here in Australia. People coming in with excessive fluid, or they just don't stay for adequate hours of dialysis, so they'll be coming in overloaded constantly. I don't know if we have any magic solutions, but sometimes people are placed on contracts to help them. So they may have to do 6 hours of dialysis for 6 sessions in order to get back to a dry weight. That's if you've got capacity in your dialysis unit. Often the dietitian is called down to, wave the finger and give them some advice about that. I think for me, part of the problem is people struggle with three things. One is the excessive thirst that comes with being on dialysis. So maybe it's thinking about, have we tried to take too much fluid off them in previous dialysis sessions, and that will drive their thirst. The second thing that drives fluid overload is excessive sodium intake. So making sure that they're not having a diet that's high in added sodium is a problem. But there's also the problem of having an excessive pill burden or polypharmacy, and people don't realize that all the little bits of fluid that you need to take all your tablets with add up to your fluid allowance. And so what we would often suggest is people take their tablets with things like apple puree rather than fluid, because that doesn't count as part of their fluid allowance. We don't encourage people to suck on ice, because that also counts as part of their fluid allowance. And in the summer months in Australia, we make sure that people understand that if you're having, for example, large serves or large amounts of watermelon, a small portion is fine, but if you're eating half a watermelon because you're thirsty, that's going to contribute a large volume of fluid as well. So it's making them aware that some foods also contribute a good amount of fluid. So it's sometimes not their fault. They're just driven by physiological mechanisms as well as a lack of knowledge. It's actually a good question, because I'm in the middle of doing a Cochrane review at the moment for understanding what strategies help with adherence to fluid and salt restrictions in people on dialysis. And I can tell you there's not many strategies that have been shown to be effective. So unfortunately, I don't think there's much in the literature to help guide us either. I think it's just trial and error, practice, making sure you understand the reasons why they're coming in fluid overloaded. Yeah, hopefully that helps answer your question, Yuri.
Yeah, I agree. Issues of compliance, especially to fluid, is quite a big challenge. And like you said, it's very hard. And again, it's case to case. Sometimes you have to look at it and individualize the situation. So just one last question from Dr. Jacqueline Shu, asking about any comments on the use of probiotics. What's your experience on the use of probiotics?
Yeah, that's a good question. And I think, unfortunately, the evidence is not there to suggest that they're helpful. What I can tell you is there's evidence that increasing the variety of plant foods in the diet is helpful for improving the gut microbiota profile. Single probiotics won't really do anything, but if you're having a diet that has adequate fruits and vegetables, breads and cereals, legumes, nuts, all of those different combinations of foods are the food for the good bugs, which then change the microbiota profile for the better. So I don't encourage people to pay money for probiotics, because it's wasting their money. There's things that they could better spend their money on than probiotics at this stage. Having said that, we did do a trial of using a probiotic containing yogurt with Lactobacillus GG in Australia. It was actually published in the Medical Journal of Australia and was highly effective at removing VRE, so vancomycin-resistant enterococcus. So in our patients that were VRE positive, we gave them a course of 8 weeks of LGG-enriched yogurt, and it was able to show that it reduced the carriage of that, and they were then cleared. Because the implications of that in our unit at least were, if you were VRE positive, you had to be dialyzed in a single room, and we didn't have capacity to put all the patients that were VRE positive in single rooms. So it was a strategy for us to help manage the cohort of people. But it needs to be taken into account that it is a source of phosphorus, and so therefore it probably should be taken with a binder. But that's about the only thing from a probiotic perspective that has been shown to be effective in dialysis patients.
Thank you, Professor Kelly. I'm sure Dr. Jacqueline's question is answered. I don't think I'll probably close it at this stage. And I want to just say thank you for the very enlightening discussion and presentation today. Looking forward to having you again down the line in the Nutritional webinar series to have more talks, because we are really learning in regards to nutrition and what we can do in CKD patients and patients on hemodialysis. So on behalf of the African Healthcare Network and our panelists, I want to say thank you, convey my thanks, and wish you a good evening in Australia. and
Thank you.
enjoy the rest of your week as it is.
Thank you. Thank you, everyone.
Thank you.